Hello again, guys. This is Dr. Viva, and today we will be discussing another topic related to the respiratory system. So today we are going to discuss collapse, various types of collapse in lung segments, and how to identify those collapse, what to write in examination, what specific attention you need to pay upon. The lecture is all about how to identify one particular collapse from another, and if you have uh, combination of collapses, then also you should be able to identify which two lobes are getting collapse. Okay, so we'll start with our lecture. So this is predominantly a theoretical lecture. This will help you to understand your concepts of lung segments collapse. Okay, so coming to the first part. So first of all, you need to understand how many lobes are there and which lobe is situated exactly where. So this is the frontal chest radiograph. Here you can see this is the horizontal fissure and this is the oblique fissure. Horizontal fissure is also known as minor fissure and oblique fissure is also known as major fissure. This is on the right side. So this is right upper lobe, right middle lobe and right lower lobe, and this is on the left side. So in on the left side there is only one fissure, that is major fissure, which divides left lung into upper lobe and lower lobe. Okay, and this is the lateral radiograph of chest. Here you can identify this is horizontal fissure and this is oblique fissure on the right side. So this is how you are going to divide right upper lobe, right middle lobe and right lower lobe. Okay, so all this part is occupied by right lower lobe. Okay, you should be knowing this because in the next part of the lecture we are going to see how the right lower lobe collapse will appear like, and what other structures you need to keep it in mind to identify and to label it as right lower lobe collapse. So this is the anatomical configuration, and this is schematic representation where various lung lobes are mentioned. This is right upper lobe, right middle lobe, right lower lobe, and this is left upper lobe and left lower lobe. And this is how the lungs will be seen on the lateral radiograph. Okay, so on the lateral radiograph you will see right upper lobe, right middle lobe and right lower lobe, and on the left side laterally if you see left upper lobe and left lower lobe. So what is collapse actually? So collapse is maybe partial or complete volume loss of the lung. Collapse is also known as atelectasis. So first and foremost thing, how to identify collapse is there will be bowing or displacement of fissure or multiple fissures occurs towards the side of the collapsing lobe. Okay, this you need to understand. Then a significant amount of volume loss is required in order to cause airspace opacification. So if your subsegmental atelectasis, subsegmental collapse are difficult to identify on the radiograph, but if there is a complete lobe collapse of the lung, then it will be easy for you to identify. And even in the examination, you will be getting a complete lobar collapse. Okay, then the collapsed lobe will be triangular or pyramidal in shape with the apex pointing towards the hilum. Okay, and the collapsed lung peripherally should maintain its contact with the costal parietal pleura except in these three conditions. So in the right middle lobe collapse, the lobe collapses adjacent to the mediastinum. We'll see how the right middle lobe collapse will appear like. And obviously in presence of pleural effusion and in presence of pneumothoracis, it is difficult to maintain the contact of the collapsed lung parenchyma with the costal parietal pleura because of the presence of pleural effusion and also because of the pneumothorax. This is just to show you how right middle lobe collapse will appear like. So this is not a complete right middle lobe collapse, but in the right middle lobe collapse, you will be getting silhouetting of the right heart border. Okay, this is how you need to identify right middle lobe collapse. This is not a complete collapse, like I said, this is a partial collapse. That is the reason you are not seeing right middle lobe collapse completely. But on the lateral radiograph, it is easy to identify and easy to say that this is a right middle lobe collapse. Okay. Otherwise, if lateral radiograph is not given, only frontal chest radiograph is given, then you can say it as right middle lobe consolidation or inhomogeneous airspace opacity involving right mid and right lower zone, predominantly involving the medial aspect. Okay, Coming to the pathophysiology, so what are the different type of collapses you should be knowing? So first and foremost thing is obstructive collapse. We'll start with this because this is a most common type of collapse. Okay, and this occurs because of the obstruction of the bronchus, or maybe due to mucus plug, maybe due to tumor or foreign objects which can block the airway, and then it will subsequently lead to obstructive collapse. Then coming to the adhesive collapse, so adhesive collapse is because of the surface tension, decrease in the surface tension of alveoli, that will lead to collapse, and frequently seen in pediatric patients, in pediatrics and neonates, especially in neonates, because of the decrease in surfactant level that will cause respiratory distress syndrome. Complete to cicatrization collapse. So what is cicatrization collapse? As the name suggests, there is underlying some fibrosis or scarring happening. Most common reason for fibrosis and scarring is tuberculosis, and that is the reason you see architectural distortion, collapse, and pulling up of the adjacent lung parenchyma along with the hilum. What is passive collapse? So passive collapse is caused by pleural effusion and also because of the pneumothorax that pushes the lung away from the chest wall. Okay, so these four types of collapses you should be knowing of, and if you understand this correctly, then always try to mention what kind of collapse are you dealing with in particular CT scan or X-ray chest, where what you are reporting. Okay. Coming to the next thing, what are the causes? So, so there are three causes: luminal causes, mural causes, and extrinsic causes. Coming to the luminal causes, which are most common because of the aspirate foreign body, predominantly in pediatric age group, this is the most common cause. Then mucus plugging and endobronchial mass. Okay. Coming to the mural, so what is mural? Arising from the wall of the bronchus. Okay. So bronchogenic malignancy is the most common cause in adults. Third is extrinsic. Extrinsic can be caused by adjacent mass. Okay, these are the most common causes of collapse in pediatric age group: aspirated foreign body and mucus plugging. In adults, like we discussed, bronchogenic malignancy is the most common cause. And just to let you know that whatever the examiner's feedbacks were there in past few FRCR shorts related exam, it is expected from candidates that you also need to identify what could be the cause of collapse. Okay, so as we have discussed, the most common, if you are seeing pediatric age group patients with collapse, then always try to mention it. This could be because of the foreign body. So foreign body could be radio opaque or radiolucent. So if you are seeing any particular type of collapse in pediatric age group, try to mention that this could be due to foreign body or mucus plugging. In adults, always try to mention that this could be due to malignancy, hilar malignancy causing collapse. So what are the signs of collapse? So there are indirect signs and direct signs. So direct signs are more important. So what are the direct signs? There are only two direct signs that you should know of. First direct sign is displacement of the fissure. Okay, we are going to see how fissural displacement will look like on frontal radiograph and lateral radiograph, and how to identify various types of lung lobar collapses based on the displacement of fissure. Then second thing is crowding of pulmonary vessels and bronchi. These are the direct signs. Coming to the indirect signs that you should be knowing of. So what are the indirect signs? First is tracheal or mediastinal shift. Second is hilar displacement. Third is crowding of ribs. Fourth is diaphragmatic elevation, and fifth is compensatory hyperinflation of adjacent lung tissue. Okay, so these are four to five indirect signs. Direct signs are only two. First is displacement of fissure. Second is crowding of pulmonary vessels or bronchi. Okay. Coming now, we'll be discussing each and every collapse according to the lobe wise. Okay. So first, right upper lobe collapse. So how right upper lobe collapse will appear like on chest radiograph. Okay. So these are the schematic representations, and this is how the right upper lobe collapse will appear like on frontal radiograph PA, and on lateral radiograph how the right upper lobe collapse will appear like. Okay, so this is the horizontal fissure. Okay, right upper lobe collapse, this is the horizontal fissure. Based on the amount of collapse, the horizontal fissure will move upwards. Okay, on the frontal radiograph. On the lateral radiograph, you can see this is the oblique fissure. Okay, this is the oblique fissure, and this is the horizontal fissure. This is the lateral radiograph. Okay, on laterally, if there is right upper lobe collapse, the horizontal fissure will also move up, and the oblique fissure will also move up. Okay, depending upon the amount of collapse. So this is more more significant amount of collapse, and this is again next stage of collapse. So as you can see over here, the horizontal fissure has also moved up, the upper part of the oblique fissure has also moved up. So both horizontal and oblique fissures are moving towards each other on the lateral radiograph. Okay, so what are the radiological signs? How to identify right upper lobe collapses? You will see opacity at right lung apex, like you can see on this radiograph. Then there is elevated horizontal fissure leading to concave inferior margins. Okay, as you can see over here, the inferior margins are relatively concave. Okay, on the lateral view, the horizontal fissure and oblique fissures are displaced superiorly and medially, like this. Okay, this is displaced superiorly and medially. This will cause atelectasis of the right upper lobe. In severe collapses, horizontal fissure will become parallel to the mediastinum. Okay, like this. This is moving up, this is moving up, this is moving up. Again, if it moves further, then it will become parallel to the mediastinum. There will be overinflation of right middle lobe and right lower lobe, leading to horizontal orientation of right bronchus and right pulmonary artery. So this will be difficult to identify on the radiograph, but can be easily seen on the CT scan if you do CT scan in such cases. And right hilum will be elevated because there is right upper lobe collapse. So these are the signs of right upper lobe collapse, and this is how the right upper lobe collapse will appear like on schematic representation, both on frontal and lateral projections. Okay, coming to left upper lobe collapse. So the one thing you should remember, on the left side there is only one fissure, oblique fissure, that divides the lung parenchyma into right upper lobe and right lower lobe. Okay, so this darker part is the right upper lobe, and this less darker part is the left lower lobe, left upper lobe, and this less darker part is the left lower lobe. As you can see over here, the as the upper lobe is getting collapsed, the left lower lobe causing overinflation, and because of the overinflation, this left lower lobe will come in between mediastinum and the collapse segment of the left upper lobe. That is the reason you will not see silhouetting of the left side of the mediastinum, and that is the reason you are going to see Luftschild sign. Okay, this is the pathophysiology why you will see a wheel-like opacity radiating from center towards the periphery, and it is difficult to identify the margin of the collapse part of left upper lobe because of the overinflation of the left lower lobe. Okay, so what are the radiological signs? So radiological signs are direction of the volume loss is anterior and medial. Okay, so this is anterior, direction of the volume loss is anterior, and on the frontal radiograph the direction of the volume loss is medial. Okay, understood? Then there will be a wheel-like opacity, maximum at hilum, and then it fades away towards the periphery. Loss of normal silhouette of the adjacent structure, there will be a Luftschild sign. So after this particular lecture, I am going to conduct sign-specific lectures as far as the lung collapses are concerned. On the lateral view, anterior wall of the ascending aorta is seen well with a good clarity due to compensatory hyperinflation of the this is because of the right upper lobe. Okay, compensatory hyperinflation of the right upper lobe, and then left main bronchus will have a horizontal course. Understood? Then coming to the right middle lobe collapse, how right middle lobe collapse will appear. So both the horizontal fissure and lower part of the oblique fissure will move closer to each other. So this is the horizontal fissure and this is the oblique fissure. So as the right middle lobe collapses, both these fissures will move closer to each other like this, and on the lateral radiograph it will appear like this. So this is the horizontal fissure, this is the oblique fissure. As the right middle lobe collapses, these fissures will move close to each other. So this is how the right middle lobe collapse will appear like on the radiograph. On the frontal radiograph, there will be silhouetting of the right heart border. This is the specific sign for the right middle lobe collapse, and on the lateral radiograph you see a triangular opacity. Okay, so best seen on the lateral radiograph, and there will be loss of silhouette with the right heart border. This is how you are going to identify right middle lobe collapse. Now coming to the right lower lobe collapse. So on the frontal radiograph, this is the right lower lobe. Okay, as the right lower lobe collapses, this will decrease in size and there will be compensatory hyperinflation of right upper lobe and right middle lobe. Similarly, On the lateral radiograph, you will see there will be, this is the right lower lobe. So as right lower lobe collapses, there will be inferior and posterior displacement of the oblique fissure, and similarly with the horizontal fissure like this. Okay, so oblique fissure will be displaced posteriorly and medially. Like we said, this is the oblique fissure, it will displace posteriorly, and on the frontal radiograph it will displace medially. Okay, collapsed lobe lies in the posterior aspect of the hemithorax, like we have discussed. So on the lateral radiograph, if you, so normally what is expected on the lateral radiograph, because of the lucency of the lungs, you will see better delineation of the lower thoracic vertebrae. Okay, but in cases of right lower lobe or left lower lobe collapses, what happens, there will be crowding of vessels, there will be crowding of bronchi, there will be atelectasis, so there will be an opacity. Because of that opacity, it is the translucency, gradually the normal translucency, increasing translucency will be lost, and lower dorsal vertebrae will not be seen properly. Okay, so there will be collapse lies. So on the frontal radiograph, it forms a triangular opacity like this. Okay, but with this opacity, it will cause silhouetting of the right dome of diaphragm, but right heart border will not be silhouetted because it is outlined by the right middle lobe. So that is how you are going to identify right middle lobe collapse from the right lower lobe collapse. Okay, and on the lateral radiograph, posterior part of the hemidiaphragm is silhouetted. So on the lateral radiograph, so posterior part of the right lower lobe is silhouetted. As you can see, this is the right dome of diaphragm, this is the left dome of diaphragm. Okay, the right dome of diaphragm is situated superiorly as compared to the left dome of diaphragm. As you can see over here, the right dome of diaphragm is silhouetted by the collapsed right lower lobe. That is the reason right dome of diaphragm is not very well seen, not very well appreciated. And normally this we have discussed just now, that vertebral column appears progressively opaque inferiorly because of the right lower lobe collapse. In normal patients, there will be increased lucency of the right lower dorsal of the dorsal column. Okay, because of the good aerated right lower lobe and left lower lobe. Understood? Now coming to the left lower lobe collapse. So how left lower lobe collapse will appear like? So oblique fissure is displaced posteriorly and medially. So on the lateral radiograph, this is the oblique fissure, it will be displaced posteriorly, and on the frontal radiograph, it will be displaced medially. Okay, so collapsed lobe lies in the posterior aspect of the hemithorax. On the frontal projection, it forms a triangular opacity. So see this, it is forming triangular opacity, causing silhouetting of the left dome of diaphragm. Okay, and on the lateral radiograph, posterior part of the hemidiaphragm is silhouetted. Okay, so on the lateral, if you acquire a lateral radiograph, there will be silhouetting of the posterior aspect of the left hemidiaphragm. Vertebral column appears progressively opaque inferiorly, like we have discussed before. Understood? Coming to the whole lung collapse. So complete, either the right lung or left lung will be completely collapsed. Okay, and because of the complete collapse, there will be displacement of the mediastinum, displacement of the trachea, there will be overinflation of the opposite lung. Okay, so what you will see on the chest radiograph, you will see complete opacification of the concerned of the respective hemithorax. So in this case, you can see the left lung has undergone complete collapse. So here also on the chest radiograph, you can see there is complete collapse of the left lung, there is a deviation of the trachea, deviation of the mediastinum, and overinflation of the right lung. Okay, most common cause in adults is the obstructing neoplasm at the level of left mainstem bronchus. There will be marked volume loss with compensatory hyperinflation of the contralateral lung. Okay, now coming to, so this is the only specific condition, and you should be knowing how to identify combination of right middle lobe and the right lower lobe collapse. Okay, so in combination of right middle lobe and the right lower lobe collapse, so why this will happen, why rest of the lobes will not show combination of collapses? Because right middle lobe and the right lower lobe will be supplied by and will have a common bronchus. Okay, the common bronchus is bronchus intermedius. So because of the obstruction of the bronchus intermedius, that is the reason you will see complete collapse of the right middle lobe as well as the right lower lobe. Okay. Here, why I'm saying there is a collapse of right middle lobe and right lower lobe, because there is silhouetting of the right heart border and there is silhouetting of the right dome of diaphragm. So you are not able to appreciate right heart border and right dome of diaphragm. Right heart border is not appreciated because of the right middle lobe collapse. Right dome of diaphragm is not appreciated because of the right lower lobe collapse. Okay. So combination of two collapses you need to identify in the examination, and this will be like, this will be asked in the examination, how to identify. These you will get similar radiograph in the examination where you will have right middle lobe and right lower lobe collapse. So you need to mention it in the report that this could be due to obstructing lesion in the bronchus intermedius. The chest X-ray signs will have right middle lobe, right lower lobe collapse, like we have discussed before. On frontal radiograph, there will be silhouetting of the right dome of diaphragm from medial most aspect to the lateral most portion, reaching up to the costophrenic angle, and there will be silhouetting of the right heart border, like we have discussed. On the lateral radiograph, as you can see, there is a silhouetting of the right dome of diaphragm from front to back. Okay, the right dome of diaphragm is completely silhouetted. This is the right middle lobe collapse, and this is the right lower lobe collapse. As we have discussed, there should be, in normal cases, there will be increasing translucency. The lower dorsal column will be better appreciated if you go down. But if there is a right lower lobe collapse, there will be an opacity, and because of that opacity, the normal radiolucency will be lost, and that is the reason the lower dorsal vertebral column will not be properly appreciated. Okay, this is how you are going to identify and write it in the report that this is a right middle lobe and the right lower lobe collapse, a combination of collapse. So thank you guys, we have come to an end. This we have covered all types of collapses, basically a short theory that will help you in your final FRCR 2B exam, and how to identify each collapse, what to write it in the report as far as shorts component of FRCR 2B exam is concerned. I will be soon uploading these sessions on FRCR Shorts YouTube channel. So thank you guys. So next lecture, I'll try to conduct it on various types of lung signs in collapses. Okay. Thank you. Bye. See you next time.